And the other thing I would say is, I think the most resonant area that, gets people's emotions going is the damage to children. Yeah. And the very effective small group, Us for Them, I think made a significant difference to government policy in this country in getting schools back open, and that was basically 3 women. And firstly, obviously they were right, morally and every otherwise, health-wise, and I think the government realised they were wrong. But I think the damage to children, the other side don't have an argument.
For the uninitiated, the glass blind spot describes the phenomenon where people consciously or unconsciously ignore information relevant to a conversation or debate about human rights because it would significantly undermine or detract from their preferred narrative. We all have our own personal prejudices or blind spots, but a glass blind spot is so big that a fucking elephant could hide in it. And the purpose of my videos are to point at those elephants. Ordinarily, I tend to focus on matters concerning sex discrimination and gendered inequalities impacting on boys and men, and I do this for 2 reasons. Firstly, because I sincerely believe that some of the most overt examples of state-sponsored structural discrimination currently in existence clearly create adverse impacts for boys and men. And if you don't believe me, I invite you to consider the quite shocking answer to one very simple question. What happens when someone calls the National Domestic Violence Helpline? A service which, over recent months, numerous UK government ministers have proactively promoted to a population faced with the sudden, unique and unprecedented experience of effectively being placed under extended house arrest.
The refugees, the charities themselves are working flat out and they're doing an amazing job right now. And they're working across the country, and it's both for men, it's both for women and also for children who too are victims, to make sure that they are not alone, that they are being safeguarded, that they're getting the help and support that they need right now because of this crisis.
The second reason I do what I do is plain and simply because so few others seem prepared to put their head above the parapet and champion this issue. There are no votes in it or kudos, very few likes to be had on social media, and pointing at obvious elephants in this area has a tendency to invite accusations of man-baby misogyny, or worse still, smears from powerful political lobbyists intent on protecting special interests by proposing that people like me, people prepared to question everything, provide some sort of gateway pipeline to notions of white supremacy, domestic terrorism, and the far right. It's the oldest trick in the book, obviously, but effective nonetheless, and obviously enough in recent months. Extremely similar smear tactics have been used to silence, discredit, or dissuade any overly enthusiastic critics of the extraordinarily authoritarian measures that have followed the World Health Organization's pronouncement of a global pandemic at the start of last year. So, speaking as someone with some not insignificant experience of pointing at obvious elephants, it's as obvious to me as it is hopefully to most people watching that the reality arising from the state's response to this so-called pandemic have by the length of a very long country mile become by far the biggest elephant sitting in the middle of all our rooms. And while I'm not best placed to speak with any authority on this issue, I figured that the one practical thing I can do is provide a summary of some of the thoughts of people who are. So in this video, I'm going to present highlights from the recent lockdown summit hosted by the group Question Everything, which attempted to critically evaluate the global response to COVID-19. And while doing so, address some of the most hotly debated and troublingly taboo questions of our age. troubling taboo questions like, do lockdowns actually work? Or do they cause more harm than good? And just before we launch into this, I want to quickly chip in my own 10 cents in the context of my particular area of expertise. Because to me, the most shocking and selfish thing I've discovered about the sort of people who so callously and mockingly dismiss matters concerning male inequalities is the extraordinary lack of regard or concern that they are prepared to entertain towards the children of both sexes who are dramatically impacted by a lack of action and empathy in this area. And I believe that the exact same criticism can be levelled directly at the door of enthusiastic supporters of trending totalitarian measures such as lockdowns, mandatory mask mandates, and perhaps most sinister of all, vaccine passports. Because, in my humble subjective opinion, the group of people privileged with protected status under the Equality Act 2010, the people apparently afforded fundamental human rights by pieces of paper such as the Universal Declaration of Human Rights and the Nuremberg Code, the people that have and will continue to be most affected by this crisis are clearly the young, perhaps most particularly children, and particularly children and young people from poor backgrounds. And for that reason, I want to begin this presentation with a compelling contribution from clinical psychologist Dr. Zenobia Stora, who very eloquently reflected on what has perhaps become the biggest collective failure of our age.
I think we totally failed children this year. And it's been really distressing, actually. I use emotive terms, but it has been hugely distressing to see, because it was completely obvious to anybody who is either a parent or anyone who knows anything about children that when you close schools, you're going to create an enormous crisis. Children become invisible, and that's so dangerous. Just in March, when the schools closed, I just finished doing an expert witness report for a child protection case. I do these things, quite regularly. And when you know about the extremely difficult circumstances in which many children live in this country, as soon as you hear that schools are going to be closed, you immediately think about those children and you think about what they're going to be subjected to. We had services that pretty much shut. So lots of the children I also work with, I work in neurodevelopmental clinics, have complex needs. So we had families with 2 or 3 children with neurodevelopmental issues like ADHD, or autism and learning disabilities. And those families lost everything. They lost the special needs schools closed, respite care closed, social workers stopped doing home visits. In December this year, I was seeing families, and I was the first professional they clapped eyes on in the flesh since March. And it is really upsetting to see, because it's been like watching a slow car crash, to be honest, because it was obvious what was going to happen. And I think that what's so upsetting is it's still going on, because you've got this. Last week, and as for them, we're doing a great job in publicising this, but we had over 11% of children out of school last week because of the track and trace system. We've had 93,000 children who are either in school 50% or less, or have been completely lost from the electoral roll since the pandemic started. 93,000 children. The impact upon their health, their life chances, their future earnings, the risk they have to, in terms of criminal exploitation, sexual exploitation. Where are these children? I find it completely astonishing, and we're still in a situation. That apparently from Monday we're no longer going to be kicking bubbles out of school. But I have no faith in this government that from September we're not going to see more school closures. I hope that we're not, because that should be the absolute priority. That children's services should be restored. That youth clubs, youth centres should open. We had reports from Wales last week about the number of children that had been taken into gangs and so on, so criminal exploitation because of the closing of youth clubs and so on. So I think if we were serious as a nation in addressing this and rectifying this and doing right by a generation that's been so harmed, we would restore normality for children. That's what we should be doing, absolutely. The children need to be living their lives uninterrupted. They need to be able to engage in the developmental work of being a 5-year-old or a 13-year-old or whatever it is, uninterrupted. And we know that they're not at risk, particularly of this virus, in any significant way. We know that they're not particular drivers of transmission, as far as I understand. So I don't understand why we're systematically harming the next generation.
Would you say then that the government and society have let children down?
Absolutely, absolutely. I think it's abusive, actually, what's happened. I know that's very strong, but I think it is abusive. Because if some of the things that have happened this year, if we were to think of a local authority looking at an individual family and saying, right, is this family able to meet these children's needs? Is this family serving these children's interests? They would say no. Okay, so this government, and as a society, in lots of institutions, schools and so on, they've implemented guidance or mandates which are actually harmful to children's development, to their emotional, cognitive and social well-being. So yes, I think it's abusive what's happened, and I think we really owe this generation, this younger generation, a massive focus to be able to sort this out.
There was a public perception and a media perception of the notion of universal susceptibility. It was thought that everybody was susceptible to this disease. And from that came the idea that we're not all safe until everybody is safe. But the narrowness of the susceptible group was actually evident very early on. As early as February of last year, the WHO pointed out that 80 to 85% of all people who contracted COVID would not require hospitalization at all. Now this, as it turned out, was actually quite an underestimate. But by the end of the first quarter of last year, it was already very, very clear that under 70s who did not have severe comorbidities faced very low risk. We're talking below 0.01% infection fatality rate. 96% of the cases in the European epidemic, the cases of death in the European epidemic, involved severe comorbidities, one or more. But this was completely ignored in the dialogue. In the World Health Organization's press conferences, there was no mention made of this fact. And it's a stark fact. The infection fatality rate for old people is thousands of times greater than the infection fatality rate for young people. Yet if you analyze the press releases of the World Health Organization, what you find is that they mention children 100 times more often than they mention the vulnerable and the elderly. The exact opposite impression is created from what reality really tells you.
We had two principal challenges. The first was the one that Jonathan Sumption championed, which was that the Public Health Act was never designed to allow the government the kind of extraordinary powers that it took upon itself to implement by secondary legislation, but without prior parliamentary approval in March. We have a particular act of Parliament, the Civil Contingencies Act, which gives the government very restricted powers, but very wide powers. And the restriction is that they need approval by Parliament, both houses of Parliament, within 7 days. And that's 7 actual days, whether Parliament is sitting or not. Whereas the Public Health Act that was used allows ministers to legislate, make law, delegated by the Public Health Act, and that comes into force whether or not, if it's used, they use the emergency procedure, whether or not either House of Parliament has debated it, potentially indefinitely, because the period within which it needs to be approved is only the period within which Parliament is sitting, and of course Parliament wasn't sitting in March and April. There was no suggestion, obviously, ever before March 2020 that could be used to impose wholesale bans on who entered one's own house, how many people one can see, rather than targeted measures on gatherings, specific gatherings. The specific reference to gatherings in the Act, and it's very obviously, in my view, not unfortunately the Court of Appeals, that does not apply to every single meeting between more than one person. It is a bastardization of that phrase. And in fact, there's previous findings of the Court of Appeal and the Supreme Court that make it very clear that you must look at the way in which the Act of Parliament gives the power, and you can't go and say, well, we say this means this, because that's not how it works. It's back to front. The second challenge that we did, we were unsuccessful on that, but with reasoning that frankly was very poor.
And Francis, can I ask, from the way you're explaining it, it sounds like it's an open and shut case in terms of and from what Jonathan Sumption has said as well, it seems like an open and shut case that the government has exceeded its authority, and yet, as you've just mentioned, the Court of Appeal and the courts seem to more often than not, even almost all the time, find in favour of the government and against what seem to be the correct legal arguments. Do you want to say something about that and how the courts have handled this?
The relationship between the state and communities, individual communities, free communities, and which doesn't mean the state, and the individual has been changed fundamentally over the last 16 months. And one of the ways in which it's changed is that the Court of Appeal seemingly didn't recognise that yes, of course, it is right that you can balance fundamental rights where you have specific targeted interventions. So you might want to ban a festival because there might be a bad virus in a particular town. This is the kind of classic way in which the Public Health Act was envisaged. But it doesn't mean, and no suggestion has ever been made before, that these measures can impose upon the whole society, irrespective of whether they are healthy or unhealthy. That is a revolutionary way of changing governance and changing the way in which we imagine the relationship between the individual and the state. There's no precedent for it. It's obviously, as Nick Hudson was saying at the beginning, contrary to all pandemic planning. It comes from an idea that was imposed in China, which the closest parallel in the West is the Middle Ages. But even in the Middle Ages, when we had the plague, which really was the plague, 40% IFR at times, we didn't quarantine the healthy even then. We quarantined with a black cross the unhealthy, those who had the plague. So even in the plague, we didn't do this. Even in the plague, and yet we're doing this now. And apparently, according to the Court of Appeal, that's just fine.
Modelers had predicted that Sweden, if it did not lock down, would suffer within weeks 90,000 excess deaths. In the event, Sweden famously did not lock down, and by the end of the year, it had experienced nothing particularly significant, between 0 and 7,000 excess deaths, depending on how you measure it. When this was observed, it should have meant the end of lockdowns. It should have meant the end of lockdowns. So what Sweden had gotten right was to separate politics from science. And what it did was sensible, and what it did, contrary to what the newspapers all said, did not result in the tragic outcome that had been forecast.
Here's another example. We've heard lots about the states. So here's two states, classic ones in America. We got Florida, we got California. Florida back in September last year decided to have no state restrictions. If you looked at this graph and you didn't know which was which, would you be able to tell which was a state that had nightclubs open with no restrictions, that had no mask mandates, that had schools open? over that period, compared to California, another sort of sunny state, both states saw a big increase in cases, and hospitalizations and deaths. But the trends were not particularly different. If anything, Florida had a lower increase over the winter. And in fact, when California started reopening from about May 2021, that sort of time when it really the death rates fell below those of Florida. Doesn't mean that's why they fell below Florida, but this idea that there's a clear, measurable impact of lockdowns simply isn't there in the academic evidence or in the data. And there's a very interesting study that came out just a couple of weeks ago from the National Bureau of Economic Research in the States, looking at 43 countries, basically every country they could get decent data on, and every US state. They control for pre-existing trends, so they try and say, well, we understand that infections may have been going up before lockdowns were imposed. We control for that sort of thing. Their conclusion, I think, is not just striking; it's really mind-blowing, I think, for the general public who have in their mind that lockdowns have been essential for saving lives. They find that, or rather they fail to find, that shelter-in-place policies, lockdowns, saved lives. But not only that, they find a positive association between shelter-in-place policies and excess deaths. In other words, they find, if anything, when lockdowns are imposed, excess deaths increase. Not only did they not save lives, lockdowns may have led to excess deaths. So forget about all the other costs, economic, social, of lockdowns. They may not have even saved any lives.
So you've got this kind of combination of lockdown, isolating people, and subjecting them to fear. So I think it's pretty inevitable. I think you predict that. And I think as a mental health professional, it's been very frustrating because right from March 2020, you'd be thinking, oh my goodness, what is going to happen? We've already got a mental health crisis in this country, certainly in my field, in children and young people. We had a crisis. We couldn't meet demand as it was. And then these extraordinary measures were put in place. So yeah, it's predictable. And what's happened is, and it's been borne out, and we've been seeing this since the beginning, the middle of last year onwards, has been research study after research study showing us that that there's been a massive increase in mental distress across the age groups, as you've said, not just in my field, but so particularly in the elderly. We've got this hugely in children and young people. It's a huge problem. Groups who are of lower socioeconomic groups, they always suffer at these times, and obviously there's lots of people who have really suffered financially, people in debt and so on. Those people are particularly vulnerable. And people with who already have mental health problems, those people have really suffered as well. So we've now got Mind's telling us, Mind in the UK is telling us that there's now, this year there's been 1 in 4 people have sought help for mental distress for the first time in their lives. The Royal College of Psychiatrists has told us that 2.2 million people have sought support this year. That's the highest ever. There's been a 19% increase in urgent care presentations for young people. So that's for things like unintentional, self-harm and overdose. And also, the Age UK, I was reading some figures yesterday because there was a new study. I mean, every day there's a study, isn't there, that's in the papers. And there was another study from UK and USA researchers who were talking about the extremely high levels of anxiety in the elderly population. Yeah. And I've seen Age UK talking about cognitive decline in the elderly. We've seen these dreadful, dreadful images of people in care homes and the way that they have been kept apart from their loved ones and kept apart from normal social contact, rise in anxiety, depression as age groups, and also with elderly people, and all of us, mental health and physical health are hugely connected, but you can't separate, particularly with the elderly, if you're shutting people in their houses and the mobility declines. And there has been an unprecedented rise in mobility issues for elderly people, either new ones or exacerbated by being isolated. Those people have experienced a huge level of need that's rising as well. And the problem is that this isn't going away. As Carol was saying, Chris Witt is telling us that this isn't over.
Yeah.
So my concern is that with this going on, and with the arguments around resilience that were put forward last year, and I personally think that expired in about May or June last year, but we're still talking about the population is resilient, and particularly young people, which I find really insulting, actually, because obviously young people are resilient, but they're resilient to terrible things like abuse as well, but that doesn't mean that we should subject them to that.
Yes.
So I think that this is going on, and we've also got a terrible economic reckoning coming, and we know that with economic recession, we see rise in depression, we see rise in suicide. Suicides are preventable, so we should be doing something about this now if we know that's coming. This is really a crisis. It's a huge crisis. And you asked me what I see in my practice. Well, I literally can't see the people that are asking to see me. I work privately, and I've had triple the amount of inquiries since January of young people's parents seeking out psychological support because they can't access CAM services, or because the children don't quite meet the sky-high threshold for CAMs now. Yeah. So I'm seeing that, and all the young people who've been in my care, most of them, particularly in the winter lockdown, January through to March, when they were out of school, I saw deterioration for all those young people. So, and we're talking OCD, very common, as wouldn't surprise you in the current climate, and self-harm, accelerating, eating disorder, those problems.
Now, I think we're all familiar with this assertion from the government that 1 in 3 of us had no symptoms but were passing it on. And there really is no evidence to support that. Healthy people can and have tested positive. They could have been immune, it could have been a testing error. And evidence of positivity is not evidence of spreading a disease. So these studies that have been done, which show a percentage of people have no symptoms, have shown really different figures. Some studies showed 4% had no symptoms, and it's gone right up to 76%. Now, a range that big makes no sense. If you were measuring a symptom like a cough, you'd expect a constant percentage. What you're actually seeing there is not a function of the disease, it's a function of the testing. The more tests you do, the more asymptomatic positives you find. So where's the evidence of asymptomatic spread? Well, what people tend to reference are modelling studies. Now, what these modelling studies do is they make an assumption that asymptomatic spread occurs. They then do lots of complicated mathematics and make beautiful graphs which show the effect that that would have on an epidemic, and they conclude that it's really important. But the whole thing is a fairy tale based on that initial assumption that it occurs. Where's the real-world evidence that it occurs? So there are reports in the literature of it having occurred. Now, a lot of these reports are of people who have tested positive with no symptoms, having been in contact with someone else who tested positive with no symptoms. And that is being described as the transmission of a disease. There are a couple of situations where people had symptoms. There was a mum with a runny nose for a day. There was a baby with a cough. But there are no cases of a severe acute respiratory syndrome or a pneumonia or somebody needing medical care because they caught it from somebody who had no symptoms.
The problem is that, as Claire has already indicated, all of the metrics are driven by the definition of a COVID case. So obviously we've got the number of cases, which I might be one at the moment, the number of hospitalisations, number of deaths. And even if the definition of a case was something that everybody agreed with, the fact that we're not told any of the critical additional metrics, namely how many of those cases are asymptomatic, how many of the hospitalisations are for something other than COVID, or only got COVID after hospitalisation, and similarly, how many of those died with COVID, not from COVID. So even if we were agreed on what a COVID case was, we're never told those critical additional metrics. And of course, things are much worse because, again, as Claire's made clear, a COVID case we now know is simply just a positive PCR test. And so it can include all of these classes of people. Those would be the true positives, but we've also got the false positives. So those are the false positives. Those are the true positives. And again, as Claire has indicated, there's some doubts about really whether those should be people who have the virus but never develop symptoms and test positive, whether they are actually true positives at all.
Let's just talk briefly about hospital transmission. This graph shows patients in English hospitals across the winter. In red, you see patients with COVID. In black, no COVID. And in green, here are the empty beds. Now, the empty beds were pretty constant. So were these non-COVID patients kindly clearing the way to make room for the COVID patients? Well, no. And SAGE have included in their report an estimate that in spring 2020, there could have been 40% transmission through hospitals. And this is what we saw with SARS-1 and with MERS. So focusing on the community, on pubs and on schools, is detracting from this. And this is really important. We could do something about this. NHS has been below capacity throughout, but ITU capacity was exceeded in spring and in winter. And it does seem that COVID produces higher morbidity. So people are more sick with COVID than they are with respiratory viruses from previous winters. But it's worth bearing in mind that the UK has less than half the ITU capacity per head of the USA and Germany. So we could be acting on this. We could be increasing our ITU capacity. We could be sorting out air filtering in hospitals, putting UVC into the filtering systems. COVID has been overdiagnosed because of bad diagnosis. We've had a poor case definition, which has resulted in people who are healthy being called cases. There have been errors in the test results themselves, which have inflated the figures, and both of these have impacted on the mortality figures, exaggerating the numbers who died. We define a disease as a collection of symptoms diagnosed by a doctor, and that doctor may use diagnostic tests to help confirm their suspicion. But that whole logic was turned on its head with COVID. COVID seems to be the result, a SARS-CoV-2 positive test result became the definition of COVID, the disease. And when you define a disease like that, what happens is a number of symptoms associated with that disease grows and grows and grows, and then you can include people who have no symptoms at all. And calling people who never develop symptoms a case of a disease totally undermines the meaning of the word case. So there are 4 situations where you could have a positive test but no symptoms. You could be in the pre-symptomatic phase of the disease. So for a couple of days, people who are going to develop symptoms can be positive and infectious, but they haven't yet developed symptoms. But you may just have breathed in contaminated air, and the air could have virus in it. But the test we do is so sensitive that that would be enough to give you a positive result, even if the virus never enters a cell. You could have a situation where the virus does enter cells, and your immune system deals with it, and you would never know you were infected, and you remain asymptomatic, but you test positive. And finally, there is no perfect test. Tests produce faulty results all the time at a low level, but there will be people who had a test error who had no symptoms. And including all of these asymptomatic positives as cases has inflated the numbers. PCR testing has been set up to detect 4 virus particles. So just to make that clear, you will be called positive when you have got 1,000 times fewer particles in that sample than is needed to be an infectious patient. And the quality assessment of the laboratories has been set up so that any laboratory that does not call a sample with 4 virus particles in it a positive would fail. So the consequence of that is that low levels of bystander virus and immune people will both be called positive tests results and then cases when they have no evidence that they are a risk to others. So what are we testing for? If we're not trying to find out who's sick, and we're not trying to find out who is infectious, if in a very upside down world, you were trying to get the highest number of positive test results, the largest number of cases, admissions, and deaths, I'm not sure you'd go about it any differently. Now, this risk of overdiagnosis is well understood. This is Christian Drosten. He is the German equivalent of Fauci, and he designed the SARS-CoV-2 PCR test. This is what he had to say about the MERS epidemic in Saudi Arabia. The PCR method is so sensitive that it can detect a single genetic molecule of this virus. If, for example, such a pathogen flits over the nasal mucosa membrane of a nurse for a day without her becoming ill or noticing anything, then it is suddenly a MERS case, where previously terminally ill were reported. Now suddenly mild cases and people who are actually very healthy are included in the reporting statistics. This could also explain the explosion in the number of cases in Saudi Arabia, and in addition, the local media boiled the matter up incredibly high.
Now, again, as Claire explained, there are multiple possible causes for false positives. And in particular for asymptomatic testing, which became increasingly widespread from the summer of 2020, this is really problematic. And there's a lot of misunderstanding about what false positives are. So just give us kind of like an explanation, a graphical explanation. Let's suppose that an asymptomatic person tests positive and there's a 1% false positive rate, i.e. 1 in 100 people who don't have the virus would test positive. Now, most people assume that a person testing positive likely has the virus, but it actually all depends on the underlying infection rate. Suppose that that rate is 1 in 1,000. Let's imagine that we test 10,000 asymptomatic people. Then we know that about 10 of those really have the virus, and so let's assume that they test positive. But because of the 1% false positive rate, about 100 of those who don't have the virus will also test positive. So out of the 110 in total who test positive, only 10 actually has the virus. And so if you test positive, there's actually less than 10% chance that you have the virus, meaning that under these assumptions, the vast majority of so-called asymptomatic cases are false positives. And in fact, with some real data, we see exactly this kind of pattern. Now, up until December 2020, when I was frequently doing analyses based on the official case data, I was highlighting the problem of showing case number plots without taking account the number of tests performed. So I'd produce comparative plots like this. But of course, these plots don't factor in the false positives. So we started to look for other key indicators, the most obvious and easily available of which were the NHS dashboard data for COVID triages. And this is highly revealing. So this was from December. You can see that the triage data at the top shows the real epidemic last spring, but just a kind of like a normal autumn increase. And that's in stark contrast to what the case data, that simply the number of cases was showing, which was, of course, driven by a massive increase in number of people tested. And that difference has continued. You can see here, this was from the last time I looked at this was from May, and those are matched up, the top and the bottom are matched up in dates. And so actually, I thought it's actually pointless to use the official case data for anything. In fact, in March, we also discovered that the Lighthouse labs were classifying positive cases on the basis of a single target gene call when the WHO guidelines was a minimum of 2. So that means that in some weeks, as many as 50% of all those classified as cases were by definition false positives. Now, all of these issues come to the fore when we look at the propaganda campaign mounted with this misleading data. this highly repeated 1 in 3 claim. Now, what is true is that when the virus is fairly widespread, around 1 in 3 people who test positive, that's as opposed to who have the virus, have no symptoms. But so what? To show how ludicrous that is, if the virus was completely eliminated, this statement would have to say every person who has COVID-19 has no symptoms. And using data from a study of asymptomatics at Cambridge University, we were able to show how ludicrous the 1 in 3 claim is. So in 6 weeks over last winter, an average of about 5,000 asymptomatics were tested per week in pools of sizes about 3 to 5. And so there were in total 43 pools out of about 10,500 tested positive. But after confirmatory testing, just 6 of the 43 pools were found to be positive, and that was a single individual in each pool. So 36 out of the 10,000 or so pools tested were false positives. And although that means the false positive rate was only about 0.35%, 84% of the positives were false. And of course, we don't even know if any of the 6 people who went on to develop, whether they actually went on to develop symptoms. And even if they did, we still can't be sure that they weren't also false positives, because the confirmatory test was also a PCR test. So overall, on average, about 1 in 5,000 asymptomatics per week were confirmed positive at a time when the ONS was estimating that 1 in 120 people in Cambridge generally had the virus. Now, we showed that if the 1 in 3 claim was correct, then the ONS estimated infection rate would be over 8 times greater than the true rate. And conversely, if the ONS infection rate is correct, then the maximum possible value for the proportion of people with the virus with no symptoms is 1 in 26 and not 1 in 3 as claimed. And finally, the problems with the PCR test also undermine the results of demonstrating vaccine effectiveness, since it's the comparison between cases in vaccinated and unvaccinated that determine effectiveness. So in large observational trials such as this one, a flawed definition of a case is massively compounded by the fact that there are completely different testing strategies for the unvaccinated. Basically, asymptomatic unvaccinated people were tested regularly, while asymptomatic vaccinated people were not. So if you don't test the vaccinated, you won't find any cases among them. And if you continually test the unvaccinated, you'll find lots of cases, almost all false positives. Now, months on, the Lancet has still not published our rapid response letter highlighting the flaws in this study.
We can be pretty sure from looking at the data from the states when states have dropped mask mandates or imposed them, and from other countries, that even if masks have a small marginal effect, which they may not at all, there's some academic evidence that says they don't at all, they don't have an effect that is observable or measurable in the data. And the idea that people are spending so much time worrying about getting rid of mask mandates when this is the first thing, where the evidence is perhaps the weakest, is, to me, really disappointing, I think, because really, I think we have enough evidence from around the world to know that this isn't the driver. Mask mandates are not the thing that will control infections.
One of the more bizarre aspects of this period is that there's been an awful silence on the left. Those who are supposedly there believing in the underprivileged, who seem so keen on state intervention, they forget that actually, to a degree, the 1% have been winners out of this. Because of the inflation, asset prices have been going up, so their houses are worth more and their share portfolios are worth more, and the rich have got richer. But believe me, the poor have got poorer.
Yeah.
And it's the 10 million who had to go out to work every day who are definitely, generally speaking, amongst the less well-off, who were at higher risk. And those, as I said, who are in safe jobs working from home with nice houses, you know, whenever I meet these people who say, actually, I've had quite a good lockdown, I have to walk away because I'm otherwise going to be really abusive. And, you know, I think they are so unnaturally distant from the vast collateral harms that have been caused right across society. I mean, to a degree, you know, you could say the economic damage relative to the sort of health harms that you've heard earlier is secondary, and I completely understand that. But ultimately, you know, pessimistic and fearful societies decline. All history throughout has shown that. And if we lose our optimism, and if, for example, entrepreneurs don't start new businesses and people aren't willing to invest because they're fearful that the government will shut them down, then the medium to long term, there will be fewer jobs, there will be less tax to pay for an improved NHS, and we will all be worse off. And if you interfere with the workings of an incredibly complicated society, as governments have done over the last 16 months by separating people and closing down businesses and so forth and so on, you can expect all sorts of negative unintended consequences and collateral damage. And the problem is that we're comparing medium and longer term harms, health and economic, with apparent short-term, in inverted commas, benefits, i.e. possibly fewer hospitalizations and deaths, although even that's debatable.
I've tried to steer people away from the idea of a devilish plan by people in a smoke-filled room, and also away from the idea that there's an agenda, and rather towards the idea that there are bad, dominant ideologies. And that links into what Luke was saying earlier. There's a current in thought, particularly at these supranational organizations, that goes along the lines of posing all the time centralist solutions that involve social engineering. And I think that we need to really examine that a lot more carefully, because it's taking over our world. That's where you get these ideas of cancel culture and of censorship. It's the attempt to impose a social engineering vision on the world. And it's very, very dangerous. It's not the first time in history that this has happened, and it always ends in disaster. So for me, I think it's wise to step back from the conspiracy type thinking or the agenda type thinking, and to really consider the ideological setting.
Can I address that as well?
Please do.
I think certainly amongst a large majority of academics involved in this, and incidentally, of course, academics have been the ones most vociferously pushing for lockdowns, and they're the ones who have absolutely no skin in the game. They don't suffer a single day's loss of earnings from this. It's actually very comfortable for them to be in lockdown, many of them. And right from the beginning, when I was on panels discussing this, there was almost a consensus from the other side that the lockdowns were generally beneficial in terms of the whole climate crisis narrative. They were actually saying things like, this would be great if we could continue this. You know, CO2 emissions have dropped since this lockdowns first began, and we need to have more of this. Okay, and I think that you cannot dismiss that. I mean, basically, what I'm saying is, I think that we're heading. This is just the precursor for climate lockdowns, and that's always been a very, very serious drive amongst a very large class of academics.
What is the underpinning of the new normal? What is the message that is conveyed by the new normal? It is basically a message that says, do not expect to live in accordance with the freedoms that you enjoyed a decade ago or 2 decades ago. In other words, the new normal for you and I is a worse normality than what we've been used to in the past. In a sense, a very clear sensibility that communicates and expresses this fatalistic view of the world. And I think that's, in a sense, really quite important for us to realize. And finally, I think one of the most important things that often escaped our attention because it took place under the surface and it evolved bit by bit is the process through which, in our culture, freedom has been transformed into a second-order value. I don't know if you noticed it, but if you look at the way in which in recent decades freedom is discussed, it's almost as if it's emptied of meaning. I remember giving lectures in the United States where some of the students quite sort of self-consciously hurled in my face the words, freedom is just a right-wing idea, or freedom or free speech is just hate speech. In other words, their view of freedom was something that was entirely negotiable. And how many times have you heard people talk about, I believe in freedom or I believe in free speech, but. And the number of arguments that you hear that try to peddle to us this new normality is really quite scary and really worrying. And it seems to me that what we have to come back and argue, and it might seem very reactive or old-fashioned or weird, is the very, very simple idea that for us, the old normal was good enough. That for us, the old normal was the product of centuries of intellectual and political and scientific struggle and achievement. That the old normal is not something that we just simply give up in order to fatalistically embrace the advice of experts who can decide for us what normalcy will be. Because what is normal should not be the product of people discussing normalcy in a laboratory. What is normal should be the product of debate and discussion between people like you and me. It seems to me it's important to realize that just about everything that is going on at present, just about everything to do with our risk-averse hostility to Freedom Day, our risk-averse hostility to going back to the old normal, is based upon important cultural forces that pre-existed the outbreak of COVID. Almost everything that is around at the moment, all the sentiments to do with the way we're handling COVID, have been around for a very, very long time, but people haven't really noticed its profound and long-lasting implications. First of all, I think it's important to realize that worst-case thinking, always fearing the worst, always imagining that every dimension of our life has to come with a health warning, has been pretty much around for a very long time. And the whole idea of the precautionary principle, which in a sense captures this, has become institutionalized over the last 2 decades throughout most of Western Europe and in large parts of the rest of the Western world. I think very, very importantly, it's important to realize that our addiction to safety, which is truly one of addiction, again has been a profound sentiment that influenced everyday behavior for decades now. And all you got to do is just remember that obsessive discussion around safe spaces, which has, in a sense, been around more or less for the last 5 or 6 years, and the willingness of large numbers of young people to embrace safe spaces, almost to voluntarily quarantine themselves from criticism and pressure, that too has been around. And therefore, it's not surprising that people who wanted to quarantine themselves in safe spaces 5, 6 years ago, today are quite happy to acquiesce to a life of isolation, self-isolation, and of quarantining. But what's really important about the idea of the freedom and safety trade-off is the idea that in some shape or form, if you and I are living freely, then we are threatening health and safety. And that's basically the premise. And therefore, the obverse of that is if we curb a little bit of our freedom, if we agree to have less freedom, then we will feel more safe and we will become much more healthy. Now, just pause for a second. Just think back to the experience of the last 18 months. We have fairly systematically traded in freedoms for our safety, as the governments would have it. We have given up our freedom of mobility, our freedom of socializing, our freedom of being involved as citizens in public life. Just about every important freedom has been traded in exchange for safety. Now, do you or does the public feel safer today because of the fact that we've traded off all these freedoms? Is it the case that throughout Britain, people are walking around saying, oh, I feel really safe, I feel really secure? This has been a brilliant experiment in social engineering. Is that what they're saying? Or are they saying today, at least a significant section of society, yes, the lockdown hasn't been all that bad. Yes, I can live with quarantine. Yes, I can adopt a lockdown lifestyle. Bring it on. Let's have lockdowns into the indefinite future, because I don't really feel safe.
The truth of the matter is, the really, really, really effective policy of the government, outstandingly effective, world class, they've frightened us senseless. Their propaganda has been the most effective in the world, which is why I've seen research that says we've been the most frightened.
Yeah.
And it's the fear that we have to remove. And once the fear goes, then the optimism and belief in life can return, and we can start to properly recover. But unfortunately, with every new variant or whatever it is, everyone gets overly scared again. And it just keeps going, and it has to stop. I think there are 5 cognitive factors that meant leadership went wrong. Groupthink, illusion of control, sunk cost, bias for action, and confirmation bias. And I think in most countries, the leadership suffered from all 5 of those, and they have caused a lot of the bad decisions.
Wow, sounds like that could do with a little bit of expanding on.
Well, the second one I think is the most important, the illusion of control. The experts and the government have made out from the beginning, they know what they're doing, and they know how to deal with it. And I think we can all agree neither of those have been true, largely.
Yeah, it's very true.
Can I also just add to that? I think that there's, over the last 20 or 30 years maybe, I think that within the population generally, I think there's a real move towards risk aversion as well. So I think that we were in a climate anyway where everyone's primed to be frightened and primed to seek the support or protection of the state. I think, from what I've seen.
I think it comes down to the precautionary principle, doesn't it, which we're seeing applied more and more widely. And there's really nothing that you can't justify on the grounds that something might happen. If we're going to live our lives on the grounds something might happen, where does it end? It's a very worrying concept that seems to have got a grip on society.
The dangers of propaganda were obvious really early on in this whole story. Countless swarms and armies of bots were unleashed by the CCP, projecting onto the world pictures of falling men in the streets and fumigation of streets and this general apocalyptic vision. Yet nowhere else in the world have these things ever been seen. They were obviously staged. And the question we ask is, what were the intelligence agencies of the world doing when this propaganda was unleashed upon the world? Were they in on the game, or were they incompetent? It's an important question.
Can't you see it too? There's an elephant in the room.